Anybody from here, please? Yes, doctor.
Dr. Christiansen, I just wanted to check with you. I delivered a patient last year. She had spent 7 years in getting pregnant. She received immunotherapy. We delivered her, and when she came back for a follow-up, I would tell her about contraception, and she would laugh it off and say, well, it took me 7 years to get pregnant, nothing would happen. And actually, 2 months ago, she had a urine pregnancy test positive. What I wanted to know was the first time she required immunotherapy to get her pregnant and tide over the entire pregnancy. So what could have changed? Is it that there's a self-immunomodulation, or does the same situation exist, or does it change for the second pregnancy?
Yes, that's a good question. Our strategy is in my clinic that if we have a patient who have a successful pregnancy after immunotherapy with intravenous immunoglobulin and have a live birth at term, then the next time she comes to have a second child, we say, try again. We will continue. We will offer you ultrasound and do hormone measurement, but will not treat you again, because our experience is that if you have first had one successful pregnancy, then something have changed, and chance the next time is much better. We don't know what have changed, but they probably have got some induction of tolerance against some thromboblast antigens that have happened during this successful pregnancy. We had an example, a patient with 10 previous early miscarriages that was included in one of our placebo-controlled trials, and she had a child after having active treatment with immunoglobulin after these 10 early miscarriages. And then after the birth, she came half a year after and were early pregnant again and wanted to have treatment again, but we could not deliver treatment because it was still a placebo-controlled trial, so we know what she have got in her successful pregnancy, so we just asked her to carry on, and she had one more successful pregnancy half a year after 10 miscarriages and then 2 live births.
Okay, Dr. Penkar, and then we'll almost.
I think sometimes we tend to make a simple problem very complicated. And Dr. Patki said just now about the endometrial biopsy. Of course, his reason for doing that is different, and my reason for doing that is different. And that is finding out whether there is a tuberculosis. Now, diagnosis of tuberculosis hasn't remained as difficult as it was when I was a resident in the year 1968 and 69. Now you can take an endometrial biopsy and do a PCR, and possibly you are able to diagnose the tuberculosis, and treating tuberculosis, it results into treatment of implantation failure, because I have had 3 patients of this kind. So let's not make a simple problem complicated.
Dr. Christiansen, this is very important in our country, where tuberculosis is one of the very big problems, especially in our infertility cases. You see, everything depends on how one looks at it. He gave me a book by Alan Beer. He has treated 7,000 cases, and he thinks everything is immunological. Anti-thyroid antibody, Crohn's disease, rheumatoid arthritis. You tell me, and it is true, all these have immunological problems, no doubt. How intensely we should treat, how much we should treat, how much importance we should give to immunotherapy, you have put it in a very balanced way. If somebody else, for example, you may say, exclude all the causes, anatomical, hormonal, infections, everything. Then only you will take immunotherapy. Is it true? Or you will do it for any case with 3 abortions or 2?
No, we only offer it to patients with at least 4 miscarriages and with no other obvious course, we investigate the uterine cavity and it should be normal. We investigate the chromosomes, it should be normal, and the menstrual cycles should be regular. And if they fulfill these things and have at least 4 miscarriages, then we offer them immunotherapy.
Yeah.